what I'd like to do is pivot from a very technical conversation to a very general conversation. I'm not a scientist, I'm not a doc, I'm not a whatever. I'm a generalist, so I'd like to pull us up a bit to a higher level and or to 40,000 feet, if you will, and begin to look at how technology could affect our world and is affecting our world. Bottom line is technology, all technology does is reduce latency. It reduces latency in the access of data or accumulation of data. It reduces latency in the interrogation of data. And it also reduces the transmission of that data in some kind of a usable form. So if we just think that that's all semiconductors and software is doing is reducing latency, it will help you to understand the huge challenge we have as we try to make sense out of what is humanity. So I think this is what I want to do. Jason?
Yeah, you just hit that button.
There we go. Okay.
Yeah. You can walk around.
Okay. Well, I'm gonna speed this up a bit. If you just think about the density of our brain, of how much data is stored just in our brain, and how interesting it is that our brain really uses about a pen light battery to drive it. But if you try to take all of the storage power and compute power that's just in each one of our brains and try to put it in a current modern day technological platform and replicate it, it would take probably 50 million times more power than the 20 watts of power that we currently use and build in our own brain. We'll talk more about this in a second, but my simple point here is the complexity of the data that resides in and around our body and the tools that you will need to really understand how we operate at numbers of level is a very, very difficult and daunting project, but we will get there. Oops. When you divide healthcare and technology, technology is a simple binary, ones and zeros process. Life is a quaternary process, ADCT. It's a quaternary language. So we're trying to replicate a quaternary language in a binary world, and we lose a lot in that transmission. But really all digital world can do is gather data, apply logic to it, and with transistors then try to transmit it back to a human use. The easy part is taking data and using these tools to improve process. So this is a Telestroke app, and it basically gathers data, reduces latency, and computes that data, interrogates that data, and gives it back to the user in a form that's very easily understood. And we know from sepsis and some other things, if we have early warning, and you know from stroke, if we have early warning, we can reduce permanent damage dramatically. And so just by latency, just by speeding up the process of data to decision makers, we can do a lot of good. But that's interesting, we'll talk about it some, but I'm more interested in big data and big databases and aggregation of data. And so where's it all coming from? I mean, we know about Moore's Law. I love Lee Hood's comment that every 9 months, the number of genome sequence doubles, and there's an enormous amount of data in genomic data. One of the pieces that, and SSF is an example of a network node. And you'll see more about that in a second, but the value of information, did I do something here, Jason? take these tools away from me. What did I do?
Jason, just forward and back button.
Okay. So Metcalfe's law is just the value of a network, or the number of the users of network values the data exponentially. So the more we can push data out, the more people get to interrogate it, the more interrogation, the more reflexivity and trading of that information, and as a result, the data gets more robust. I love Wurr's law, and that says that with all the computational speeding up, reducing the latency from Moore's law, that it really is slowing down because software is asking hardware to do much more difficult things. We'll talk about that a little more in a second. And here's just a graphic representation of one data point. As the price of sequencing genomes goes down, the numbers and the amount of data stored is exploding. And that gets back to Lee Hood's law. I like this metaphor because water is, I'm an English major, and water is used as an analogy for life in lots of things. And I also like the notion of a pivot, because I'm going to pivot from just kind of an overview of basic data to something a little more infrastructure-wise, because I like to think about compute as a utility, like electricity. We should be able to plug in the wall and get all the compute power at your level that you need. And I like to look at what you do, and I mean it in a positive way, and where we mostly look at utility of computational power is really the sprinkler head to the plant, the doc to the patient, where the value creation really is going on. But there's an enormous amount of work and infrastructure behind, and I want to go up that infrastructure a bit so that you can get kind of an understanding of what will be possible and what's coming. Back to first Jens's comment, we do have a really curious pathway that we've kind of been dropped into serendipitously, and mainly it's because of our association with Boeing. And it's fun, those of you that know Israeli research, Technion and Incitec comes out of the defense industry, so a number are focused ultrasound, and those tools are coming out of the defense industry. We really got started big time back in the 70s when B1 and B2 and gallium arsenide chip growing facilities were being built. And we built a bunch of encrypted computer labs with scientists, and we evolved at the same time the technology to support those with encryption, uplink satellites, and all kinds of other technology breakthroughs, including photovoltaic cells and other kinds of power sources that were used on the lunar, or on the Earth or the space station, and so on. And from learning and associating with those folks, we learned that a lot of what we found out was not venue specific, that it actually there were multiple applications in the healthcare space. And you'll see one little snippet at the end of my little pitch of a UCLA doc and Oculus and migration through a brain from the inside of three-dimensional matter. We built and owned and designed the first cellular switch. My cell phone has one of the first ever phone numbers in the cellular environment. So I can remember Craig McCaw talking about, wouldn't it be great if we had 50,000 users, and they look back about how understated, I mean, they're ubiquitous, they're everywhere, and people have multiple devices now. Where technology is going to take healthcare, I think, is equally as impressive eventually. And so the more we can know early on, and the more we can build robust infrastructures that will future-proof our systems for the kind of demands that are going to be put on that infrastructure in the future is absolutely important. And I'm here to tell you, in the world, we have the best infrastructure, the most robust infrastructure, and I'll show you that in a second. So we're ready. And this node which is a network on a network of nodes, is just the beginning. One of the things that most people don't understand, or because it's just not taught, is that hydropower is only a small portion of the total power production in the United States. Turns out that Washington has almost 50% of the total hydropower potential in the United States. So what? Back to rivers and life in that analogy, so I'm following it. Columbia River is a big deal. The Mississippi and the Tennessee and all of that, Tennessee, TVA, those are big rivers, but there's no grade. We have grade, and since we're on the West Coast, grade, I mean, Eastern Washington, the drainage area, 3,000 feet down to sea level in a short period of time. We're on the West Coast, so we have a lot of water. So what? Oop. Jumping around. So what? You saw the first slide, and you saw the 50 million times power that you'd need for compute power to just equal the brain. Computers take electricity and electrons. It costs a lot of money to move electrons. It costs nothing to move photons through fiber. So if you look at the difference in the cost of 1 megawatt across the country, you can see that Quincy, Washington actually has the lowest cost hydroelectric power in the world, and that we say is legal. There's probably some places in the world where you get it cheaper, but probably not market-driven economics. So that's a huge advantage for us for a number of reasons. BlackRock, VMware, Amazon, they're in Eastern Washington. Why are they in Eastern Washington? Because in a 10 gig or a 20 gig a megawatt demand, the numbers against their EPA or their PE versus Santa Clara to Washington is a big number. It means a lot to their shareholders. So I've done a TED Talk, and in that TED Talk, I said that the Columbia River is curing cancer. That's a pretty big gap. How's the Columbia River curing cancer? It's simply because the amount of compute cycles that are required to interrogate how cancer moves and evolves is going to be solved in Eastern Washington because of the Columbia River. So, as a result, this is Quincy, Washington. Boeing is there, Yahoo's there, big chunk of Microsoft's cloud, Dell, in this little farming community. Why? Because they understand the value of the power. We were the first ones there. We convinced Google to go there. So we've been in the very beginning of this for some time. Since we're on Facebook, I'm not going to necessarily read these names, but I'll point them out to you, and I will read a couple of names, and so I can say Providence Healthcare, their entire database resides there and is interrogated from there. I can tell you that the New York Genome Center, Bob Darnell, the 9 research institutions, including Cold Springs Harbor, are in Eastern Washington. Why are they in Eastern Washington with us? Because they understand the value of these low-cost compute cycles. They understand that being there as we begin to aggregate these big data sets, that we will be the only place in the world that will have the power at a price you can afford to drive the interrogation and comparisons and so on to be able to make sense and to be able to give you and Charlie and others decision assist tools so they have a whole other dimension of data as you make your clinical decisions. And these are going to be really big, and we'll talk about a little bit more in just a second. We also, most of the virtualization movies, all of the animation from the major companies in the world are done here. So most animated movies you see, they're laid up in this facility in Eastern Washington. One point is once content is removed from its physical form, think Netflix or think records removed from plastic to digitization, but also think about blood and all the information that's in blood, tissue. All that material has information, but once we lift it from those physical forms, we can then begin to interrogate it. We can then begin to ask questions of it. We can compare it. And then we can ship that information anywhere in the world for free. If you think about Eastern Washington, it's like Google search. And this is why the New York Genome Center is there. We store the data there, but they send the algorithms and the interrogation tools to the Center for Computation and Interrogation, and then send the solution sets back. Because transport is moving at near the speed of light, the latency between Eastern Washington and Europe, or the latency between Eastern Washington and Tokyo, is less than 120 milliseconds latency round trip. So that's why when you get on Google anywhere in the world, bam, they do an interrogation of a data set, and that data set may reside in Ashburn, Virginia. That data set may reside in Eastern Washington. It may reside in a number of places, but you'll have access to that information in a very short period of time. We sit on this is global lambda infrastructure. And that's our communication pipe, SSF, and we use it all over the country and all over the world. So in theory, one day, we'll be able to interrogate cancer, compare new cancers to old cancers, speculate about what the evolution of those cancers are, what drugs will affect this cancer or that cancer. But we'll be able to assist docs in Sao Paulo. We'll be able to access docs in Irkutsk, all over the world in nanoseconds. So we're already doing this. We set up the the Luxembourg Center for Systems Biology with Rudy Balling in Luxembourg. Bob Darnell is in our network in New York from the New York Genome Center and Rockefeller University, and Lee Hood, with a little luck, will be moving onto this campus in the next bit. But they're all using that unified resource. So back to the pivot, and back to 00. This is my sequenced genome. That's me. That's the recipe of how my body was built from inception. I'm told that my mom has a lot more of the genetic material in here than my dad does. I don't know how that happened, but I think that's a good thing. We will all have our genome sequenced soon because they tell a lot about us, but that's only one dimension. We will also have besides our genome, we'll have our microbiome, we'll have all our clinical labs, we'll have all of our metabolites and proteins, and we'll model them. And so just the genome is a big piece, but the number of microbes in and on our body is 3 times the number of cells in our body, and those interactions have important parts, have important impacts on our health. And the balance of the microbes in and on our body has important impacts. Maybe not so much in the beginning, but as we go through life, they take a toll. And so as Dr. Hood talks about, we have an optimal, an ability to optimize our genetic potential, but all this epigenetic stuff, all these stressors that we have from life pull down the optimization of that potential. The problem is few of us understand that, and as a result, we can't take any corrective actions to change that. And since I'm so different from you and so on, we each have a different set of activities and tools that we should be using to optimize our opportunity. Healthcare costs a lot of money, and we have an aging population. all of you know the Hayflick limit, and the idea is to optimize your health to the Hayflick limit, and then kind of like Ogden Nash's poem of the one hoss shay, that everything was all built the same and it collapsed, everything collapsed at once. The idea is to push us healthy for as long as we possibly can, and then hopefully we'll get out of all the clinical activities that we need to have because we're healthy. But until you understand this data, you can't really make good decisions for yourself. So if you think about data and data accumulation, you saw that first slide where we were talking about genome accumulation, but then there's all this other data, and then that data is accumulated from inception right through life, so you can begin to think what a personal kind of data movie of you, a life movie, is going to look like. And it has importance because your body begins to react to stressors by creating certain proteins at very low levels that are detectable in your blood that can give pre-diagnostics for onset of disease function. And if we can catch them early enough, we can stop any kind of irreparable damage, or at least we can slow down or manage the process before it creates issues. All of us will have one of these one day. So why did I talk about the DAM and Quincy and compute cycles and so on? It's because you can begin to see the platform that's being laid down and the things that are going to be setting on top of it, and the interrogation that's going to take place, and the improvement of life as a result, and that we're sitting right in the middle of this space. Now, when does this roll out? I don't know. I'm 70. Well, I'll be 70 actually next Monday. But I feel pretty good. And I've been following Lee Hood's 100-person pioneer project, and I have seen absolute positive changes in my health over the last 5 years because of this process. But think about the youth, the youngsters, that if they started on a process like this very early on, how much further ahead they could be. We're going to stand up an aging vertical, we're going to stand up a number of things, and they have to do with memory loss, and the things that go on in memory loss and Alzheimer's and all that are all related to how our body works towards its Hayflick limit. At any rate, there's all kinds of layers of data to be gathered, but as David Hanscom knows, there's another layer in the human experience, and that is thought and thinking and our emotional stress on our physical activities, and that adds a whole nother layer of complexity. We know the brain is dense and so on, but I'm going to pass that, except for to do what our brain does now, it would take 1/3 of the Columbia River to mimic one brain. That's what 1 gigawatt looks like. So it's pretty overwhelming. I won't waste a bunch of time on this. Here's where we are with current EHR EPIC. It's a pretty facile system. It's a data collection system. The latency is terrible in the transmission and so on. So, as Jens suggested, I'm really interested in how human beings work, how the human experience, how this wonderful machine works, and as we get into understanding how it works, we'll be able to design all kinds of disease therapies and clinical therapies and decision assist tools and so on. But where the quick opportunity is in healthcare right now is simply in process improvement. Just taking current data that you have, accumulating it, interrogating it, getting it back to you in a much faster pace so that you can make decisions sooner. I won't bore you with a description of EPIC, but I will tell you that one of the things that we've done which is a joint venture between us and Providence, is we've created a massive data lake, and we use data lake, the water metaphor again, and basically all these inputs of data, which will include AirAvail and your personal data, and then build an ontology and dictionary over the top of it, an intelligence layer, and then an interrogation layer using a number of different tools to interrogate this data. And then we've pushed it, and we're pushing it up into Google's big table in a HIPAA-tolerant environment, which will mean we'll have access to it in ways that no one else in the hospital community has access to compute cycles, data transmission, and a number of things. This is the beginning of the infrastructure to provide the power for the tools that you guys will invent, because you guys are the guys at the sprinkler head to the crop where the value is created. Our job is to build the infrastructure so that whatever you invent, whatever you evolves, that we can support it. And the good news is we have future-proof anything that you can bring it on, I guess is another way to say it. This is the future. This is an air traffic control center. We call it a care traffic control center, a net operating system for a massive hospital system like Providence. There'll be screens and ED throughput, and Molly's going to demonstrate a tool here in just a second. There's prediction, stroke apps, a number of things that will be process improvement tools.
It's just amazing to see every little opening in the skull where a nerve goes through it.
At the University of California, Los Angeles, neurosurgeons are slipping on virtual reality headsets to go inside their patients' brains.
I'm virtually inside the skull of the patient, walking around, floating around.
Dr. Neil Martin is the chairman of UCLA's Department of Neurosurgery.
I think this is going to have a tremendous impact.
He's developing this virtual technology with Modi Avasar. How did you get from flight simulation to virtual brain surgery?
We allow the pilot to fly through the scene of tomorrow's mission, and that's exactly what we're allowing a brain surgeon.
Avasar started out creating 3D models of the brain for computer screens by combining elements of flight simulation software with traditional brain scans. Now Avasar has taken that technology to the next level with this virtual reality headset. Put it on,
Yeah, it looks like you can almost reach out and touch them.
and you fly around inside the brain, moving past brain tissue, nerves, and blood vessels by simply moving your head.
Now you can turn your whole body.
Okay.
It's like being there inside the vessels, inside the brain.
Oh, wow.
Brain surgeons often operate on tumors and aneurysms dangerously close to areas that control language and movement. They do it through a microscope and an incision the size of a dime. This technology would allow them to practice before the surgery, and during it, they can put the headset back on to reorient themselves.
Here's an example. Right here on the image, I can see the carotid artery going through the margin of the tumor. Rather than have that all of a sudden appear as I am removing tumor, I'll know exactly when I'm going to encounter it. That is a big improvement.
An improvement that he believes will ultimately benefit patients by making surgery shorter and more successful. And within weeks, he plans to be the first neurosurgeon using these virtual views to save real lives.
So we have a joint venture with Google's Magic Leap. We built their lab. It's right down here in Georgetown. Google's technology way exceeds Microsoft's technology and their Oculus tool. What we have coming is absolutely magnitudes of order beyond this piece. So we have all of our MRIs, tools, all these other tools to look into the human structure. We're going to have much more advanced tools. And even like your spine that you just had up on the screen, you're going to be able to walk around the spine and look at all sides of the spine. You're going to be able to even go down as low as getting inside of a protein and look at a protein folding, which is causing stenosis and these other things. And you'll be able to find the site of where the perturbation is taking place that's causing these particular issues. This is an exciting space, and really, again, all we're doing is reducing latency, we're gathering data, and then we're gathering that data, interrogating that data, or putting that data in a form that you can use, simplistically use. And remember, we think in pictures, we don't think in words. So if we can visualize these structures up close and personal, our brain's ability to process that information will be much quicker and much more exacting and with much less error. And as a result, the decision strategies are going to be much more robust and much more exciting. Healthcare is the most data-dense space in the world. There's nothing more dense than this space. But as I showed in those first slides, we're in a simple binary world, and it's one or two-dimensional, but it's going to get a lot more interesting. So stay tuned. We've got to pay the bills, and so we're taking the tools that we have right now and applying them to systems that we can improve. And here's a process tool that I just want to have Molly give you a quick show of what we're doing in ED throughput. Molly?
Sure. Can everybody hear me all right?
Yes.
Yeah, I think so. So I work at Multiscale here, which is on the same campus with you over at the Jefferson Tower. And the good news is you saw that picture of the data lake. We capture our essential product and process at Multiscale is we capture everything right as it goes into Epic. All the keystrokes, the time that everybody does everything, which makes for an immense database. So the good news is we have a lot of data. The bad news is we have a lot of data. We need help from clinicians and operators at hospitals to tell us what's important, what's meaningful versus what's noise, because we can capture everything. So some thought leaders here at Swedish asked us to take what was a report that they were getting about every 6 or 8 weeks on ED flow and connect real-time data to it, because their conviction was that if they could have information about the process of patients moving through the ED, they'd have an opportunity to improve throughput. So what you're seeing here is a map of all of the EDs in the system, the Providence system, and we are working with 2 teams, one in Tarzana, California at Providence Tarzana Medical Center, and one in Spokane at Sacred Heart Medical Center, to really help us understand which data tags, which data pieces are going to be most meaningful to them. So I'll hone in on Sacred Heart. At any one time, you can see, and the operators love this, you can see the health of any individual ED arrayed across the system. So if you go to Sacred Heart, then what you start to see is a diagram of, I've just selected a cohort of patients. These are patients who arrived in the ED up through this morning, starting about 2 weeks ago. I chose all manner of arrival. You know, in Alaska, sometimes we see people coming in on sled. Whatever arrival mode they had for the entire time frame, and then whatever type of discharge they had for all complaints. The only thing that I narrowed down is to say that how long were they in the ED, and these are patients that were in the ED from 6 to 12 hours. So you start to see that the ability to do process tagging for everything that happens with this group of patients really gives you the ability to start to select which data elements are most important to start to look for opportunities to improve any kind of process. I mean, there's some processes in the ED, obviously like chest pain, that are very prescribed and have a very, straightforward set of process pieces, but that's unusual. Most patients, there isn't anything like this. So the ability to look very close to real time and see what is happening, and as you can see with this group, you have all the data tags. The reason we're working with the folks in Spokane and in Tarzana is to understand which of these data tags is meaningful, which ones, if you took them out, you wouldn't lose any fidelity of information, but you'd have a clear picture of what the opportunities are to improve. And so the emergency department. So the emergency department doesn't want to render, but the basic filter that we have built in is what gives us the opportunity to select all these various data tags, and that's the kind of work that we're doing with the folks from Spokane and Sacred Heart, is to tell us what kind of things do you want to filter immediately. So we've created this real-time dashboard. We've already been told dark background, not so good, so we're working on that. But the idea is that if you can see
things like a delay in the provider to disposition or disposition to discharge. What can you do right now to improve process? So again, a lot of data, and we're working really very hand in hand with multidisciplinary clinical teams at these two hospitals to understand the best way to display this data.
David?
So, quick question. This is through the Providence. You did
Yes.
this? So, Kevin, are you familiar with this? So, we've spent 8 months developing this massive database for every spine patient, pain clinic, physiatry, spine surgery.
Mhm.
And we're trying to create a dashboard every patient every time is completely automated. So it sounds like we're talk.
Yeah.
And we're to the point now we have this data being collected, we don't know how to create the story around it.
Okay.
So our whole thing is quality through accountability.
Sure.
So every patient, every time will have a profile of red, yellow, green, of anxiety, depression, sleep, stress, osteoporosis, smoking, etc. Every time, every patient. So we have a dashboard that's individualized. So we're 2/3 of the way along developing that, but this is something that would be extraordinarily helpful.
So is the data that you're extracting, Kevin, is that all coming from Epic?
This is actually through a third party called Tonic.
Oh, Tonic, yeah, the patient satisfaction stuff.
So what, and it's why I wanted to talk mainly about infrastructure, but give you 2 little teasers on modalities or at the end of the pipe. And it's why I said, we're building the infrastructure. Your job is to find the tools that will help you run your practice and improve your practice, and then set it on top of our system, because we have the distribution, we got the pipes, the ping, and you can run it across multiple hospitals, because we're down at Kaiser and we're a number of places. New York Langone loves this ED throughput tool because of the traffic in New York City, and they've got about 8 EDs there, and so where their resources are to match up their patient needs and so on, and traffic and so on. Putting a Google map over the top of this in real time is, all it does is reduce latency, but it does increase patient outcomes. But your job is to work with us to find ways to take your tools and proliferate them and to make them better.
Yeah, those are exciting because we have about 2/3 of it done. We're lacking this, and we didn't honestly know about this. So this is.
So healthcare is a very cottaged industry, and there's all these people working in silos, and it's one of the points of Seattle Science Foundation, and this was Dr. Lee Hartwell, the Nobel Prize winner, who was one of the original board members of Seattle Science Foundation. His comment, his descriptor, his cocktail speech, elevator speech was a trusted convener. We don't care who gets the benefit. All we want to make sure is that the patients get the benefit and that we improve outcomes. There's a number of people working in all parts of the world on various aspects of things. If we can find a way to get them all together, this process is going to move much faster. That's the idea behind SSF, is to convene, to get people talking, to have conversations like this where we've got in a Sarbanes-Oxley tolerant space where you can talk to industry and you can talk to research and so on, and find solutions so we can reduce from basic research the latency to applied science. It's that simple. Questions? I mean,
so first of all, one fear factor. So this data is awesome. It's a great data integration display. I just hope that the Chapman Clinic wait times won't be ever displayed above it.
We're outing you here.
I don't want to have an insulated
So
state.
you know, on the sign for you, the restaurant says, if you are waiting, you're in the wrong place.
All right.
Yep.
On the real life scale, so there's still this kind of distrust of artificial intelligence serving as a surrogate decision maker for us in healthcare. Just a case example, the first case we showed earlier with that failed hardware, if we used AI, first of all, the patient probably would have not had the surgery. That would have turned out really bad, so in all honesty. But then in terms of the troubleshooting, the board answer was what Charlie said, a big open anterior procedure from the opposite side. And again, somebody who's an outlier, like the individual Rod Osgoodian's skill set would have not been taken into consideration. It doesn't appear as a blip. So personalized medicine, in terms of a reduction of personalized medicine to an AI kind of a binary decision-making process with multifactorial input versus the individual skill set, personalized medicine versus individual care. Where do you see that evolving? When is the American public going to be willing to make that switch?
The American public isn't going to make that decision. We're going to make it happen. We're going to work together to accumulate all these databases so you have comparable data, and so that you'll be able to, I have this case, and just like a Google search, I have this case, compare it to multiple other cases that very quickly, we'll go into the database, find them, give them to you, spread them out. This was a solution set, which will give you that multiple, the benefit of other people's ideas. That's coming soon. One little bit of diction change or vocabulary for you. Artificial intelligence. There is no such thing as artificial intelligence. Machines aren't intelligent. What our brain does is intelligence. That's what separates us from rocks, is life. And that intelligence, and I'm not beating up on you anyway, I just want to make this point because it's a big one. And there's a big fight in research. It should be augmented intelligence. All we're doing is we're augmenting, much like all the other tools, we're augmenting basic systems. And so I want to expunge that because it kind of denigrates how complex and the beauty of what's really going on in our brain as we do with a pen light of energy, the things that we do. So small point, but augmented intelligence. Charlie.
Algorithms sort of in the cloud, plus something like UpToDate, which is the latest prospective randomized sort of controlled analysis of the right way. And just like an error veil, when you get your data, you're in the red zone, and then you move to the yellow zone, and then the green zone. If physicians would see that, look, the way you treated this patient is on the red, in the red area compared to compared to the data-driven assessments, that could have a huge impact, because a lot of people are out there practicing 30-year-old medicine and not really in tune with current cutting-edge information, and it may move people. I mean, not tell them you have to do this, but kind of like you don't want to be the outlier, and it could show your expense of your treatment is like you're an outlier, so that could move people toward a.
We learn from each other. I mean, that's a basic human thing. We learn from each other. The problem is, or the opportunity now is, we have these tools that go across massive others,
Right.
and so Sandra back there is smiling a bit because we've had conversations with, when you raise the term radiation, with astronauts, and that there's some sense that some people are more susceptible to radiation damage than others. So there's a whole series of things that we don't know yet that is going to be very helpful. And what we've tried to do is slowly but surely, and it's the purpose of my conversation, was we've built the platform with the power. Now we need to start populating it. And so we have software here in Jim Harding's team, and they're aggregating a bigger and bigger software program because software is a big piece of this. And then we have clinical delivery here. And then we have visual content delivery through this platform. So we're loading on these platforms, and our job is to build that platform, throw the match on the gasoline, and then stand back and watch it go, because we are beginning to and continuously attracting thought leaders in various spaces. And that's the purpose of today's conversation. Thank you.
What you just said, so we know textbooks are obsolete by the time they get published, that is old. And so all of us physicians, we are always sort of going to the internet, we're always looking for the last paper published, we're trying to get into each other's journals, we use PubMed. And this is and you were talking about the silos, oncology has lots lots of silos, conventional treatments, people that stand guard to protect how things have always been done versus more emerging things like basic surgery. It's been out for 20 years, but trying to gain acceptance in that conventional oncology world. So I think you're right. This is a great avenue to break down these silos, and the more subspecialists we get talking, the more data gets added to cross-reference with surgical oncology, the better off everybody.
We are in the infancy of that process, as I think you all are aware. What's possible, you can let your mind wander. I mean, you know what's possible. So we have a lot of work to do, and there's some low-hanging fruit just in process optimization. But what really interests me is just the human experience and the epigenetics of how our systems and our genetic communities interact with our systems and those changes, and how do we optimize that and all that good stuff.
We have a big problem. So I did a review article for Jens Journal, the Global Spine Journal. And I looked at hundreds of articles about the standard of care for spine. There's sleep, there's stress, physical conditions, medications, diet, all this stuff that should be done before somebody has surgery. So another paper said only 10% of surgeons are actually assessing those variables before they do surgery. So it was incredible watching hundreds of research papers, probably thousands, documenting clear standards of care, and we are not implementing them. Now there's a bunch of papers showing that doctors simply don't follow the standards. So this situation is interesting, because this case here is pretty upsetting to all of us in the room. You want to do no surgery, you must have 2 major risk operations which changed your life. So if you're going in real time, if 1,000 doctors were to get that one scan beforehand, and 900 of them said, don't do anything, that would make a difference. So we're not implementing the data that we know. I think that's the next wave of medicine, is we're publishing articles that show really great things, and we don't implement them. So I think that's the next step, is how we implement what we already know.
And that's basically what this is we're taking what we already know, organizing it in a fashion that you can do something with it. The amount of computer technicians and data analytics people, that space is going to explode as we aggregate that data and then organize it in a way that on a dashboard that makes it simple for you to use, because what you don't have is time. And then why put all this junk into your brain that's obsolete? And so our job is, I'll end where I started, all technology does is reduce latency.
So what's interesting about this, we're also putting up a program where we're going to start reviewing every case we do on 4 more levels before we make a surgical decision. That takes time.
Sure.
So there could be a way of setting up a protocol with this, where the surgeons can all weigh in on a given case, bam, and not spend time every week going over these cases. That would be very interesting also.
So my job is to build the infrastructure. Your job is to find the ways to connect with software people and clinical data and point those people in the right direction.
We got the spine stage. We just need to create the multi-scale SAGE project right here. I'll show you that. So the leap.
Thank you.
Thank you.
Thank you, Dave.